Welcome to the December issue of the Journal of Vascular Surgery. These next 4 great papers are available for your review for free for the next month. We would also encourage you to read the other outstanding papers in this issue of the Journal of Vascular Surgery. The first paper, which is our CME paper of the month, is entitled Risk Prediction of 30-Day Mortality Following Lower Extremity Major Amputation by Jolison and co-authors from Boston. They created a simple risk prediction model to identify the factors associated with a 30-day mortality after lower extremity major amputation for ischemic vascular disease, using the Veterans Affairs Surgical Quality Improvement Program data. From 2005 to 15, they identified 14,890 patients undergoing elective above-knee and below-knee amputation for critical limb ischemia, that is rest pain, tissue loss, or gangrene. They used 2/3 of the data to derive a prediction model and 1/3 of the data to validate the risk prediction model, with the primary endpoint of 30-day mortality. The predictors of mortality included preoperative DNR status, congestive heart failure, age greater than 80, chronic renal insufficiency, above-knee amputation, dependent functional status, coronary artery disease, and chronic obstructive pulmonary disease. These risk factors were then combined into low, moderate, high, and very high risk. Overall, the overall mortality in the derivation data set was 4.6%, while 30-day mortality was 2.3% for low risk, 4.3% for moderate risk, 7.5% for high risk, and 17.5% for very high risk patients. These data can be used to provide counseling for patients, as well as benchmarking data for quality initiatives. The next paper, Endovascular Treatment of Spontaneous Renal Artery Dissection by Zhang and co-authors from China, assessed the outcome after endovascular repair of patients with spontaneous renal artery dissection. 14 patients with acute or chronic hypertension developed flank pain. Endovascular repair was technically successful in 14 of the 15 and significantly improved hypertension in 86%, and follow-up imaging showed no sign of renal artery stenosis or occlusion. The next paper, Upper Extremity Endovascular Interventions for Symptomatic Vascular Access-Induced Steal Syndrome, or VAS, by Chun et al. From San Antonio, examined the outcomes in patients presenting with VAS. 28 patients presented with upper arm VAS and 70 patients with VAS below the elbow. When above the elbow, 1/3 of the steal patients had subclavian and 2/3 had brachial artery disease. Patients with subclavian disease underwent stent placement, and patients with brachial artery disease underwent balloon angioplasty, with technical success of 100%. 91% had symptomatic success at 30 days, and the remainder required proximalization of the access. Of those with disease below the elbow, 42% had either ulnar or radial artery occlusion. Balloon angioplasty was performed in 1 vessel in 55% and in 2 vessels in 45% of patients. Technical success was 79%, but only 51% had symptomatic relief at 30 days. Of those who remained symptomatic, 80% required proximalization of the access and 20% required ligation. The authors concluded that interventions for Steal syndrome due to above elbow disease are associated with a high rate of success, whereas interventions for below elbow disease have a poorer success, with more patients requiring secondary procedures and low long-term survival of the access site. The final paper and the editor's choice for this month is long-term survival after EVAR and open repair in patients with anatomy outside of EVAR IFU criteria by Charbonneau et al. From Canada. 202 EVAR patients and 220 OSR or open surgical patients with at least one anatomic IFU violation were compared. EVAR patients were older and less likely to be hypertensive, while open repair patients were more likely to have proximal aortic neck IFU violations. The all-cause mortality was 37.6% and 21.4% in the EVAR and OSR groups respectively, with a median follow-up time of 5.2 and 5.4 years. Aneurysm-related mortality was 3.5% in the EVAR group and 2.2% in the open surgical group. The authors concluded that patients with IFU violations have longer and higher long-term survival with open surgery compared with EVAR. We hope you enjoy reading these 4 papers and the rest of the excellent papers into the December issue of the Journal of Vascular Surgery. And thank you for your attention.